The new International Prognostic Scoring System, based on the incorporation of the molecular data, has been published online in the New England Journal of Medicine Evidence in June 2022. It's a real pleasure for me to discuss with you the implications of the new diagnostic and prognostic IPSS-M and the general impact of this scoring system on the prognostic outlook of these patients. My name is Theo de Witte. I'm a clinical hematologist and scientist working in the research departments of tumor-immunology and hematology at the Radboudumc University Hospital in Nijmegen, the Netherlands. My interest in MDS was initiated about 4 decades ago when we started to treat MDS patients with allogeneic stem cell transplantation and intensive chemotherapy. I was the coordinator of a range of clinical studies in MDS, both prospective and observational in the EORTC, EBMT, and last but not least, the European MDS Registry and the European LeukemiaNet MDS Working Party. First of all, we should realize that the existing risk scores, including the original IPSS and IPSS revised, were mainly based on cytogenetic characteristics, percentage of marrowblasts, and cytopenias. However, around 50% of patients with MDS have a normal karyotype. This precludes a definite confirmation of the clonal character in 50% of the patients. This is especially relevant for patients with low blast counts and low risk scores. Moreover, quite a few studies have shown a specific prognostic impact of several molecular abnormalities, including SF3B1 mutations with a good prognosis and ring sideroblastic clinical characteristics, and TP53 mutations with poor prognosis and complex cytogenetic abnormalities. The International Working Group, the IWG, evaluated clinical and molecular variables in almost 3,000 patients diagnosed with MDS with less than 20% marrowblast. The final analysis have been published in New England Journal of Medicine Evidence Online as of June 12, 2022, very recently. These patients were evaluated for alterations in 152 genes in diagnostic or peri-diagnostic samples prior to disease-modifying interventions. A set of independent prognostic variables was identified, and the relative weight of these variables was estimated using appropriate models. Genomic mutations were detected in 94% of patients with MDS with a median of 4 mutated genes. Multivariable analysis identified multi-hit mutations in TP53, FLT3 mutations, and MLL partial tandem duplication as the most relevant genetic predictors of adverse outcomes. Mutations in ASLX1, BCOR, EZH2, NRAS, RINGS1, STAC2, and U2AF1 were also significantly associated with an adverse risk for the 3 main endpoints: leukemia-free survival, leukemic transformation, and overall survival. In contrast, SF3B1 mutations were associated with favorable outcomes, but co-mutations influenced this favorable impact to a great extent. The intended use of the IPSS-M was to assess the relevant risk posed to the patients by the disease itself. Therefore, confounding variables, including age, sex, and MDS type, were later included in the model fit, but not in the risk score itself. Analysis of somatic mutations of the 31 most relevant genes in combination with hematological parameters and cytogenetic abnormalities resulted in a unique IPSS-M for individual patients. The absolute neutrophil count was not independently prognostic in the IPSS-M model and was excluded from the IPSS-M in contrast to the preceding IPSS-R. The cytogenetic risk categories as used in the IPSS-R have been maintained in the IPSS-M. 6 IPSS-M risk categories with prognostic differences could be derived from this risk score, ranging from too low, too moderate, and too high risk categories. Death without transformation was very dominant in the very low and low risk groups, while in the very high and high risk groups, patients died equally with or without AML, indicating that the great majority of patients with MDS will die from other causes than transformation to acute leukemia. Furthermore, the median leukemia survival ranged from 9.7 years in the very low risk group to only 0.8 years in the very high risk group. The IPSS-M risk categories improved prognostic discrimination across all clinical endpoints and re-stratified 46% of the patients when compared with the IPSS-R. 911, 74% of the patients were upstaged, and 312 patients, 26%, were downstaged. More than half of the patients classified as IPSS-R intermediate shifted, including 63 of the 321% upstaged to the very high risk group. Patient re-stratification was usually based on cumulative contribution of multiple prognostic mutations for each patient rather than the effect of one single mutation. An open access web calculator was developed based on the data obtained in this study to simplify clinical use of the IPSS-M in close collaboration with the International MDS Foundation. The calculator returns a tailored IPSS-M with the corresponding risk categories and the time estimates for leukemia survival, leukemia-free survival, overall survival, and AML transformation. The calculator also accounts for missing values, in which the IPSS-M risk category is calculated under the best, average, and worst scenarios. The calculator is accessible through the International MDS Foundation, but the Android and Apple version will be available in the near future. Now some general remarks on the IPSS-M score. It is clear that the incorporation of the relevant molecular mutations in MDS will be a major breakthrough in the diagnostic and prognostic evaluation of untreated patients early after diagnosis. Its prognostic value in patients with CCUS, clonal cytopenias of unknown significance, needs to be proven by similar statistical approaches as in patients with proven diagnosis of MDS. One important question is, how representative is this large group of almost 3,000 MDS patients? These patients were selected from 24 centers that were performing NGS analysis at an early stage of introduction of these techniques. This implicates that the candidate patients were referred to large, mainly academic centers. Unfortunately, the age of the patients was not mentioned in this communication, but I assume that the average age was significantly lower than in population-based patient cohorts. Moreover, the data of this selected cohort of MDS patients were analyzed retrospectively, precluding appropriate interpretation of interventions usually starting a considerable time after diagnosis. Specific molecular patterns, including SF3B1, TP53, FLT3, or RDH1 or 2, may benefit from tailored inhibitors irrespective of the overall prognostic classification. IPSS-M is using hemoglobin levels as a continuous variable, while patients with hemoglobin levels lower than 8 grams per deciliter are usually regularly transfused, even early after diagnosis. Red blood cell transfusion dependency by itself is a prognostic variable associated with a negative impact on outcome. Unfortunately, I cannot go into the details. It's clear that IPSS-M is a great step forwards compared to IPSS and IPSS-R, but it should be validated prospectively with general observational studies and well-designed prospective randomized interventional studies, including transplant strategies. Last but not least, prognostic scores like IPSS-M should include a well-defined vitality score and other objective measures of the so-called inflammatory comorbidities. Thank you for listening.